The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Now, I've been asked to say that the primary responder should be the responder should be the primary team rather than the outside team. And I guess a lot of what Charlie said is actually enforcing that. All of the MET systems have consultation with the primary team as an early step in assessment of deterioration. But one of the things I think we have to think about is that the setting really determines what you should do. And one of the things we really haven't teased out in this conference is there's a lot of difference between running a rapid response team in a tertiary hospital like I have with lots and lots of resources versus running one in Kempsey, all right, a small regional hospital. So in our ICUs, none of us ever have a MET response into the ICU. Why? Because the ICU rounds in a multidisciplinary way on every patient at least twice a day. They look at what's going on with the patient. They decide, preempt, predict, and intersect. In Charlie's example of putting someone on CPAP to solve the immediate problem and then not thinking about why the hell are they in pulmonary edema and what can I do to fix that, is exactly what happens in ICU. We take it the step past fixing the physiological problem to go and look at why that physiological problem was developed. So we never have a MET response in our ICU. We never have a MET response in my ED. It'd be crazy. There's enough nursing and medical expertise in that ED not to need me to come and muddle around. And I put it to you that there are other places in some hospitals that don't need a rapid response team response. That's where the clinical teams look after the area in an old-fashioned way. That means there are senior doctors and senior nurses and junior doctors and junior nurses who mentor their juniors, who round, who deal with problems, who do all those wonderful things that Charlie had on that slide that I could go back and replay, and I'd say that is a properly functioning ward team. Okay? So in my hospital, there's the haematology ward has, I'll put my hand up, they've got sicker patients than most of the patients in my ICU. All right, they are seriously sick. But they're looked after well because the clinic is on the same floor as the ward, and there's a consultant and a senior registrar in that clinic and that ward every moment of the daylight hours, and they round twice a day on everyone's patients, and they make decisions, and they're proactive, and they look after the people. So there are wards where you definitely don't need a rapid response team response. There are other wards, though, where you definitely do. And I put it to you that they're characterised by, say, an orthopaedic ward in my hospital. So the orthopaedic surgeons choose to do a ward round at 6:30 in the morning. At 6:30 in the morning, they meet the night nursing staff, who are coming off the end of their shift and are buggered, basically. And the orthopaedic surgeon wanders around and gives his majestic wave from the end of the bed at all the patients. Nothing's decided, no one actually examines any of them. Then the ward nurses are left to have to try and mentor a junior resident or intern through the day. And then at 7:30 or 8 o'clock at night, the consultant will come in and do exactly the same thing. So that sort of ward definitely does need a rapid response team. So you see where I'm going? We're actually developing an ambulance service. This ambulance service goes out and rescues people in the hospital that are situated in wards that aren't working properly. So, you know, medicine's moved on a lot. Charlie was talking this morning about the development of ICU in the 1960s and 70s. Similarly, emergency departments went from sort of generic A&Es. I still look back at my early days when the medical superintendent of the hospital or the surgical superintendent of the hospital would run the emergency department. And if you were a junior doctor in the emergency department, what would happen towards the end of the day is the medical superintendent would come down and see all the patients that were deemed medical and throw about 30 of them out. You don't need to be here, go and see your GP. You don't need to be here, go and do something else. So ED only really developed in the 1980s and 90s to look like it does now. What's happened to our ward care? Nothing. So Florence Nightingale would recognise the care we give patients in our ward. Nothing is different now to when she was working in wards. Now, she was a clinical leader, and her main claim to fame was working in the Crimean War. And in the Crimean War, lots of British troops were dying from cholera and diarrhoea. And what Florence Nightingale did was send nurses to Turkey, and within 6 months the mortality rate had dropped from 42% down to 2%. Why? Because she did some simple things. She reduced overcrowding, made sure the beds were more than 3 feet apart. She increased ventilation. She got rid of the horses that were underneath the wards. And she arranged to flush the sewers. Okay? As well as that, she kept meticulous records and is said to have done quite a lot of work around statistics and geographic display of statistics. Now, how would Florence Nightingale respond to what's happening in our hospitals now? I put it to you that she would recognise that a geographically stable multidisciplinary team for every ward would actually stop the problem. And that multidisciplinary team rounding appropriately at least twice a day and with senior medical and nursing staff on hand to deal with deterioration would mean we wouldn't need a rapid response team except for the very rare event of a cardiac arrest unexpected. So subspecial teams like the surgeons or the physicians, just like in our ICU and HDU, would come in and pontificate about whether you could pull the drains out today or maybe tomorrow. But all the normal care, whether the patient gets nutrition, whether they get fluids, what their physiology is doing, whether you give them a diuretic or not, what their medications are, is determined by the geographically located senior multidisciplinary team. So I put it to you, 3 hypotheses. Rapid response teams depend on the setting, and some settings you definitely need them and some settings you don't. The second hypothesis is what we're trying to fix is something about the way the wards aren't working. And maybe we need to put a bit of attention to thinking about what that is and what we might do about that. And third thing is, you know, you can have a rapid response team for lots of things. This is a Billy Graham rapid response team bus, and they respond to disasters. And I put it to you, our wards at the moment are a bit of a disaster, but we could fix them.